think we should be good to go. Good morning, good afternoon, good evening, everybody, and welcome to this ITHOM and Markable Thought Leadership Panel. Perimenopause, do we need diagnosis or rethink the entire care model? This is Pankaj Gupta from ITHOM Venture Partners. We are a deep tech revenue scaler and fund based in Singapore with approximately 120 startups in our portfolio. These are all AI, ML, blockchain, IoT, robotics, AR/VR startups from different parts of the world, stages and sectors. And now we are more focused on healthcare. We are running approximately 50 healthcare innovation days, demo days, thought leadership panels, roast sessions every year, and we are onboarding more than 20 healthcare startups a year. Today, we are hosting this conversation with Markable, and we have Revital and Dana, who are the co-founders of Markable with us. We have a fantastic panel to talk about the discussion around perimenopause. Perimenopause affects millions of women worldwide, often starting in the mid-30s to early 40s, yet it remains one of the most under-recognized and mismanaged phases of women's health. If you look at the statistics, recent data show that while more than half of women aged 40 to 64 experience related symptoms, only 8% receive a formal diagnosis of perimenopause or menopause. Nearly 40% report feeling misdiagnosed, leading to delayed care, unnecessary treatments, and years of unnecessary suffering. We are joined by leading experts in women's health, innovation, investments, and patient advocacy to really unpack this question across different critical themes. Obviously, their insights will challenge assumptions and point toward a better future. Now, I would request our panelists to introduce themselves so that we can learn more about their background and the kind of insights that they will be sharing throughout this panel. If I request Kate to go first. Kate, please.
Thank you very much. My name is Kate. I'm a specialist women's health nurse. I specialise in particular in fertility, POI, premature menopause, and menopause itself. I work a combination of working independently, supporting patients with consultations, work-based training, and I'm also a nurse lecturer at Essex University in the UK. And I'm also studying a part-time PhD, which is looking at women's lived experiences of premature menopause. And thank you very much for the invite.
Fantastic. Thanks a lot, Kate, for your time today. I'm sure that there are a lot of interesting insights that you're going to share from your experience in the hospital ecosystem. So really appreciate your time today. Nivedita, could you please go next?
Sure. Thank you, Pankaj. So my name is Nivedita Agarwal, and I'm part of Siemens Healthineers, based in Erlangen, Germany. That's the headquarters for Siemens Healthineers. And I lead the public-private partnership and the innovation funding team within Siemens Healthineers. And the main motto for us is that healthcare cannot be done in silos. So we have to work in an ecosystem together with our clinical partners, together with startups, together with external partners, pharma companies. And that's where the vision of my team is also of how can we orchestrate and build these ecosystems where we are working together. And women's health is, of course, one topic which is very close to my heart. So I'm happy to be here. Thank you.
Fantastic. Thanks a lot, Nivedita. And since you're working with all these major stakeholders of this ecosystem, I'm sure that there are a lot of interesting insights that you will bring on the table today. So really appreciate your time today, Nivedita. Revital, could you please go next?
Yeah, sure. Well, I'm Revital. I'm the co-founder and CEO of Markable. And we're building a smartphone-based platform that tracks how perimenopause actually shows up in a woman's body. Through visual biomarkers, cognitive patterns, and symptoms tracking, so women and clinicians can finally see the full picture, not just through a single blood test or a urine test to show a snapshot. That's our mission here.
Thank you. Thanks a lot, Revital. And obviously, while you are building a startup, building a new product from scratch, it requires a lot of innovation thought process. It requires a lot of research. So I'm sure that you may have gone through a very interesting journey. So we would love to hear your insights from that journey today. Dana, could you please quickly introduce yourself?
Hi, my name is Dana Inbar. I'm co-founder and CPO of Markable. And together with Revital, we're trying to build something new and exciting.
Fantastic. Thanks a lot, Dana. My first question, so just to talk about the themes, we will first talk about the diagnostic, the challenges, delays, inconsistencies, and so on and so forth. After that, we will move on the symptoms-based versus data-driven care, right? What is more important? Where do we see results? And then we talk about diagnosis versus management, and then we look into the future care model, how it should look like, what is more scalable, how do we create a more personalized and continuous care model for women. So let me start my first question and let me kickstart the first theme on diagnostic with Kate. So Kate, if you look at the current, diagnostic challenges, delays, inconsistencies, if you look at current criteria, they heavily rely on irregular periods and FSH levels. FSH levels, fluctuate quite a lot. Yet many women suffer symptoms years earlier. What are the biggest systematic and technological reasons for diagnostic delays and inconsistencies today that you have seen in your experience, Kate, please?
A really good question, Hagaj. What I would reflect from 20 years working in the UK is, first of all, education. A lot of women haven't had that education about their reproductive cycle, what to expect in terms of their menopause journey. We're 51% of the population as women. We're all going to go through the menopause at some point in our lives, yet a lot of women I see aren't always prepared for that transition. And as you say, also that transition that might start to, they may start to notice many years before periods start to become irregular. And often from a healthcare perspective, we often use patients' periods as a guideline to say, oh, well, where might you be in your menopause journey? Because we've got that wonderful definition. Well, if you've gone through the menopause 12 months and one day after your period stopped, then that's all we need to worry about. But I'm pretty sure a lot of the ladies on the call here and anyone listening will agree that there's so much more to it. So I think, first of all, it's seeing it as a journey rather than kind of getting to that one magic day. And then a lot of things might start to happen before periods completely stop. And also reflecting back on education, that blood results such as FSH can be useful. They're particularly useful when I'm seeing ladies who are much younger, who might be presenting with premature ovarian insufficiency. But like anything, bloods don't always tell us the full picture. So when we're thinking about delays and getting results or working our way through the pathway, it's not just, well, we need to do a blood test and that will tell us that complete picture. It's looking at that patient in front of you, the person, what's their clinical history, what's the symptoms that they're experiencing, because actually it could be really, really individual. And I think the individuality hugely contributes, because you can't apply, well, we do this for everyone and we offer this treatment for everyone, because when it comes to menopause, that really doesn't apply. It's very much individual to each woman.
And do you think we have enough technologies, enough diagnostic tools for the customized diagnosis today? Okay.
If I had $1 million and I won the lottery, definitely not. I would love to be able to offer my patients reliable ways to say, well, if we did such particular test or we did such particular monitoring, we could tell you this, and we could tell you more about your menopause journey. And unfortunately, at the moment, that's not just something that exists, but also realistically, when I'm looking at patients in the UK who are being seen in the NHS, we're not realistically able to offer enough diagnostic support because it doesn't exist. And also, I'm sure everyone on the panel will agree, women's research has been notoriously underfunded and underprioritised for many years. So whilst at the moment we don't have the research and evidence for more diagnostic tools, with more investment and more growth in research, could we move into that direction? That would be amazing for our patients, wouldn't it?
That's true. And I think this is where the work done by Revital, Dana, and Nivedita comes into the picture. This is where they do add a lot of value into the ecosystem. So my next question is to Revital. Revital, how do gaps in diagnostic tools and technologies contribute to these delays And what role can innovation in diagnostics play in closing those gaps from your perspective, Revita?
Well, I have to say we keep getting that question. I mean, why do we need to diagnose it? A physician can just question the patient and understand their symptoms map and just treat them. They don't need a diagnostic test. And we really encountered this question, I think, so many times. And I think that the data speaks for itself, because when you have less than 10% of women globally receiving any kind of treatment for perimenopause, which is a stage that now is recognized as being so crucial for future health, for having the potential of reducing major risks like cardiovascular disease or cognitive decline. Further on, I think the data really speaks for itself. I mean, if it's less than 10%, it doesn't exist. So I think the tools have to come in. And the problem is that the orthodox tools, they provide a snapshot on a very fluctuating, evolving situation. So we see that, I mean, that's actually why we enter this space. We said, I mean, if you build it, maybe they will come. You know, if we have something that can show it to them. If physicians have such minimal training on this subject, and it takes decades until you close this gap in medicine, usually. So we said we don't have that time for women. We want something right now to help navigate, help the doctors and the women better understand themselves.
Thank you. Thanks a lot, Revital. And Nivedita, from your perspective and from your experience, have you encountered diagnostic tools or technologies that can avoid these kind of delays, inconsistencies in the space, or while you have been building the ecosystem at Siemens Healthineers?
Yeah, so before I start, I think Siemens Healthineers is not in this space. So whatever I say, it's more like my personal opinion about it. We are in diagnostics business as well. So we do have blood-based biomarkers, and we are also researching a lot with saliva, oral biomarkers, and things like that. I think that's more the future. But what Revital and Kate were referring to, that the physicians are not well educated, or they don't feel fully aware of what tools are, even though if there are tools. And the other thing is, I think this has to be shifted a little bit towards like hospitals at home, that you need easier diagnostic tools that the women could use probably at home, which makes things a little bit more easier. So that's my perspective on it.
Okay, and what about wait and see approach? What kind of human health costs we are talking about because of that wait and see approach? Kate, probably you may wanna respond to that from your nursing experience.
I would add that sometimes in healthcare we will wait to see what happens with, and I'm just talking on a general consensus in particular conditions or symptoms, to see how the patient progresses. But thinking about the patients I see regularly, they often kind of feel that they're trapped in a circle of symptoms. So you've got this circle of menopause symptoms where you might have difficulty sleeping, you might have a low mood, you could have night sweats, you could have vaginal or urinary symptoms. And it's almost like you want to be able to say, let's see if we can break the link in that circle and help the patient navigate those symptoms. And I suppose if we're kind of watching and waiting rather than taking any proactive action, we're not offering the patient any way to kind of break that circle and some of those symptoms. So I think it's very much about balance, and it's very much about, as I've said previously, looking at the patient in front of you. What exactly are they struggling with? Because sometimes kind of watching and waiting may not be the best course of action for that patient, because they might really be struggling with symptoms, and that might be impacting on their lives. They might be struggling with work. They might be struggling with juggling family. We know a lot of women, if we're thinking about menopause at the expected age, are juggling many family commitments, older parents, teenagers, family life, work life. But also in terms of when I'm thinking about the particular area where I specialise with younger patients, we definitely wouldn't really want to kind of wait and see if we had a patient, we were suspecting a premature menopause who was in their 20s, because of the implications of not having the right treatment at the right time.
And let me ask this question to all the panelists on the call. Do you think insurance companies are contributing enough to resolve these challenges, or they are not completely involved into this ecosystem in the right manner? What is your opinion on that? Anybody?
Sorry, you were saying which companies? I couldn't.
Insurance companies, the payers.
Oh, I think from my perspective that I hear a lot of talk about prevention, but I think there's not really enough actual focus on prevention. I mean, we are building this tool. Hopefully, in a few years, insurers will start, to actually rely on it and not just incorporate it. We hope that will be much sooner. But I mean, to really rely on it to have their, the outcomes improve through time. But I mean, currently, there's not enough, especially in this space, being done to prevent the difficult outcomes that usually come later in life.
Okay, so from your perspective, insurance companies need to up their game, especially in this particular space. Yeah. I think Kate and Nivedita, you wanted to add something to it.
It was just really in recognition. I completely support that. There's a huge amount of work to be done when we're thinking about the implications of long-term health and menopause, such as cardiovascular disease, for example. So it's really just completely supporting that it's not just thinking about symptoms in the short term, but how do we support women to live, live well as they age throughout their life.
Thank you.
Yeah. I think from my experience, so in general, if we look at the women's health journey, it was like, I think initially it was more focused on the fertility side, and now slowly there is a hype coming on this menopause and perimenopause and things like that. And even working with the insurance companies, so it's also like a cycle or a journey with them. So they come more when the things are getting more matured rather than the early. So whether it is now women's health or this or cardiovascular diseases, or even like non-communicable diseases like cancer, etc. So if you move really in the preventive space, you hardly find reimbursement or insurance companies doing and I also understand, because they need evidence to basically reimburse. And for evidence, you need to do more clinical trials, you need to do more research on it. And this, I think it's still like at that phase where we are gearing up with more funding for research in women's health. And I think it will come, but it's not there.
Okay.
I just want to add to that actually I completely agree that there are those trends with insurance. When you look at the data is there. I mean, when you look at the biggest research ever done on women, they know the impact of actually treating those hormonal fluctuations during this life stage. And if you look, if you compare it to breast cancer, for example, and having women take mammograms, which is supported in many places, I mean, you think about the impact that has, the fact that women can go and take those mammograms and in prevention. And when you think about the risk reduction that's possible here on the perimenopausal menopausal journey, I mean, there is a miss, because you're talking about a 7-time increased risk for cardiovascular disease versus breast cancer for women. So how come nobody's working on preventing that? There is a mismatch here.
So probably more education, even for the insurance companies, for the payers, more white paper, more research, more such roundtables, conversations are extremely important to create that education awareness for the leaders, CXO leaders in the insurance companies and the payers. Makes sense. Now let's move towards symptom-based versus data-driven care. And Revital, my question to you is, the solution, marketable solution that you are building, it's non-invasive visual biomarker and symptom-based pattern approach, which is trying to solve this particular challenge. How can multimodal data help determine the issue and provide the right care to the women? Revital, please.
Well, I think that we're not talking about, I mean, there's a lot of focus on is a woman, if a woman is in perimenopause or if she's not, and then if we give her a hormonal replacement therapy or not. And we think that you need to fine tune those answers and actually, expand the picture much more. I mean, there are different patterns in perimenopause. You see women with more vasomotor symptoms, some with more cognitive. You see the different trends during the transition. When sometimes it starts more with the cognitive and mental side, and then later on the vasomotor comes in. And we feel that using the multimodal pattern, our multimodal approach, you will see those patterns. You will see which women benefit from specific treatments at each stage. I mean, those who actually really focus on midlife care, and I mean physicians that are actually focused on it and work on it all the time, they have those nuances of treatment that most physicians don't have, but they still don't know how to align it to the different patterns of women. We can already start seeing it in the data, and hopefully we can combine the two and give the physicians the tools that they need in order to provide a more accurate treatment plan and bring to better outcomes. It takes a really long time to get a woman really balanced back to hormonally and to reduce the symptoms. And when you see it through those different models, if it's cognitive, if it's their symptoms, or the visible biomarkers, they actually start to get to balance back. You see the improvement. I mean, doctors even saw it before we show them the pictures that we're taking. They can see it when a woman walks in. Many of them say when she walks in, I know if she's on hormonal treatment or not, if she's getting back into balance or not. Kate, I see you nodding. Please feel free to jump in. But that's something that's really apparent. And we're just trying to take that gut feeling that the real experts have and actually make it into a model that can be common use for every, even possibly GP, but especially OBGYNs that focus on midlife women.
And do you think doctors today or OBGYN today, they are trained to use those models, use that data, make the decision, provide the right kind of care, or more training, more education is required to make it happen?
We hear it from them all the time, much more training. I mean, they're the first to say they hardly spent any time studying this initially during their medical training, but even further on during their work in the ongoing training they go through, there is hardly ever any done specifically on perimenopause or even menopause, but perimenopause is even a bigger black hole. So they definitely need to get specific training from those experts that stepped in the past few years to actually dive deep into the current data and research that was done, and to change the current working, frames of working, provide better care.
And Nivedita, from your perspective, how this data, how this model can add value to the OBGYN, to the patients, to the women, and what are the barriers to adoption? I mean, obviously, the training for doctors is one barrier, but what are the other barriers that you see in terms of scaling, innovation funding, adoption, and so on and so forth?
Yeah, I mean, so of course we need like a balance of symptoms-based and data-based, prediction of what's happening. And both have to come together. I think what the other panelists are also saying, that we need longitudinal data. And of course, this kind of biomarker data helps us to track the journey over time. And now taking it more on a higher level, what we see as always like challenges in these digital world or AI world now is like fragmentation of the data. So you have data coming from EHRs, you have data coming from different biomarkers, you have data coming from imaging reports from that. And how do they, come together? Are they speaking the same language? So that's always like and the more data doesn't give you the more insight. The quality of the data is the most important one.
Right.
If you feed in like biased data, you will get the biased results. So
Right.
you have to really use that. And I think in the end, these what AI can do is like it can give you the patterns, but it has to be really so easy for the doctors to understand, and it has to be a decision support system, not a complicated system that they're not able to use. So I think these are some of the challenges that we see also on not only women's health, but also in other disease areas.
Right. So, Kate, from your perspective, let's say when OBGYN or doctors have a lot of this data coming from different sources, who probably may be contradicting, or whom or these data set may not be probably collated properly. How do doctors make a decision, or who is the master? Is the data master, or the doctor is the real master? Who is the master over here? How do we solve that adoption challenge with all this information which is coming in?
A very good question. I suppose the first thing I'd add is obviously my background is obviously a nursing background, and
Right.
whilst there are many OBGYNs and doctors working in menopause, there's also, particularly in the UK and Europe, a whole allied health professionals, including nurses, paramedics, physios, all sorts of different allied health professionals working within menopause care now, really reflecting that it is a multidisciplinary team approach. So I suppose my gut would say, sure, it's the human approach that matters, but it's when you're making that human decision, it's knowing that you have all the data to make an informed and supportive decision for your patient, but also have you had the appropriate training to feel confident about interpreting that data? Because numbers can tell us lots of things, but then so can a person in front of us, and numbers or data might not reflect how that patient feels or what they're telling you about their journey. So I think as the panelists have mentioned before, it's about having that education and that confidence to look at the full picture, which might include the patient. It could include other data and biomarkers and information.
Okay. Makes sense. And now let me move to the next theme, which is diagnosis versus management. So, Kate, again to you, if symptoms are severe, but a woman doesn't meet formal diagnostic threshold, what do we do? Should the system still provide full support? What is your opinion on that?
Absolutely, yes. Support should still be there. As we said, a person isn't just based upon what their blood results say or the data. And in fact, I was only just talking about this morning with a colleague about a particular patient. As you say, the blood results are normal. The patient's in her early 40s, but she's still experiencing symptoms, and she's still coming forward and saying, "Look, these symptoms are impacting my quality of life." Absolutely, we should always look at the patient in front of us and continue to support and treat, provided that we're working within our limitations of practice, our scope, guidelines, and also that we're not afraid to seek support from other clinicians or members of the team who might be able to help that patient. It's looking at that patient as a whole. I think from a professional healthcare point of view, absolutely, we should be supporting the patient at every step. But when we're looking at healthcare, that's not always something realistically that we're able to do. If you ask any healthcare professional, again, I was only talking about this with my students yesterday. What do we really suffer with? What impacts us? It's having that lack of time. We would love to spend more time with our patients, but we're not able to. You know, a GP in the UK may have 8 to 10 minutes with a patient. Is that enough time for the patient to get across how unwell they're feeling or what's happening with them? So I think the time factor is a real challenge, because most healthcare professionals want to support their patients, but the time factor is a big issue.
Interesting. So you believe that you should look at the symptoms more than only at the data. You can't just look at the data and make the complete decision. Makes sense.
Yes.
Nivedita, from your perspective, is chasing a formal diagnosis in such a long and variable phase actually delaying care, or how should we rethink about this?
I mean, the thing is, the whole healthcare perspective is that how can we reduce the time to treatment, right? So that's where we want to go. And that will depend a lot of, how the data from different sources are getting integrated, how better the physicians are informed about each of those things, like what Kate was mentioning. I mean, 7 to 8 minutes per patient, it's not enough. So, and I think diagnosis is like the first step of really getting to know, okay, what's happening with you. But then overall, in the treatment process, how you're getting informed on day-to-day basis for that makes a lot of difference also on the patient experience side. So of course, there are a lot of innovations that are happening to, reduce the time to treatment in all different fields. But for that, the whole ecosystem has to somehow come together. Right now, MR machine will not talk to CT machine, and you need all those, and then it doesn't talk to the final wherever your biomarkers or sensoric data is coming to. So we have to get that everything in place that will support reducing the time to treatment, but that's definitely needed.
So innovation has to play a big role in making sure that these systems are talking to each other, and ultimately the right diagnosis, right care could be delivered to women. So Revital, from your perspective, when it comes to scaling and innovation, how do we move toward prioritizing actionable management over rigid labeling, right? That, hey, even if the diagnostic threshold is not met, there has to be proper treatment, enough care that should be given to the women.
Well, I think that first of all, saying that the diagnostic criteria has not been met is one of the key problems here, because there really isn't such a thing. It's supposed to be driven by the information that the woman provides to the physician. That is almost globally how it is supposed to be determined if a woman is perimenopausal or not. Then your reality checks in, exactly like Kate said, and you have like an 8 to 10 minutes with their physician, including the time that they need to prescribe. So nobody has that full conversation that needs to be had, and to get to grasp the real picture of the symptoms that the woman is actually is having to handle. And when you're talking about a condition that has approximately, I mean, you have different numbers, but we see about 100 symptoms that are being talked about in perimenopause. And again, the lists are different from 34 to more than 100, but there are so many symptoms, and it's just not realistic to have that short period of time with your physician to be the place that you need to actually start discussing them. It's impossible. Even those who really deep dive and have a full session of 1 hour on the first visit, they can't talk about everything. That is exactly why we came in, because we saw that women are demanding to get this treatment that is actually walking them through the treatment plan, seeing where they stand, where they improve, where they're not. what is working and what is not. I mean, when you have so many symptoms, it's so difficult to understand if you are actually improving or not. You have biases both ways. I mean, sometimes something that was really painful for a woman and really disrupted her life can actually overshadow, if it improves, it can overshadow many things that are still actually getting worse underneath, and vice versa, of course. I mean, negativity bias is very strong here as well. So again, women are demanding to have those tools that help them manage, and they're willing to pay for it, and they're actively searching for it. And anyone that has now a platform that they speak about it and can teach them what to do, and they spend their time, they go, they listen, they learn, they invest in it because it's their well-being. For many of them, it's really disruptive for their life on a daily basis. So again, this is at our core.
Interesting. So let me, ask this 8 to 10 minutes. Is this pretty common globally, or it varies from country to country? And I know that we have panelists from different countries. So is this 8 to 10 minutes?
It varies in what they say. I mean, the reality is that it changes in real life. Some days probably changes in every country. But if you say in the UK, they talk about like an 8 to 10 minutes. And I can say that also we see it more in the Middle East as well. And in the US, they might refer to 15 minutes. It doesn't really matter. Even if it's 15 minutes, it doesn't matter. Only in private, very premium care, you might be talking about 1 hour sessions. And again, it's usually only for the first time, for the first intake.
So I see Kate nodding in complete agreement. So even if you offer 30 minutes, you can't really cover all, 50, 60, 100 symptoms within that time frame. Okay.
I wanted to add that, Nivedita, you said it earlier as well, that that you actually need to provide more time to talk about the treatment and actually dive deeper into that part. And I mean, we want to take the intake part out of the equation to allow for the visit to be focused on how they can actually fine-tune the treatment and adapt it to the specific woman, and really have the doctors do what they have been trained to do. I mean, yeah, and the main focus on how to get the women to feel better.
Okay. Kate, did you want to add anything to that?
No, I think that's absolutely right. And absolutely that, yeah, there is a huge difference. Sadly, only commenting on the UK for what's offered for NHS treatment versus what's available for private appointments. So again, that creates that whole divide on what you're able to access based upon what you're able to afford or what's available on the NHS. And as we said, it's thinking realistically from that patient's point of view. How do you navigate 10 minutes to be able to get across all the symptoms that you're experiencing and then flipping back to the healthcare professional's point of view? Well, which symptom do I focus on? Or am I thinking about menopause, or am I thinking about ruling out other health conditions? Because as we know, other menopause can be a consideration, but so could other health conditions.
Okay, interesting. So in which bucket do you really put this specific symptom?
Absolutely. So for me, I'm constantly thinking about fertility, menopause, women's health,
Right.
because that's what I'm doing day in, day out. But your general practitioner, your practice nurse, who might they have seen before you? Is it a baby? Is it granny with blood pressure? So menopause might not be the first thing that comes to their mind. Right. And a lot of people say to me, what do you talk about in your appointments with your patients? And exactly what panel members have said. Patients want the time to digest the information. They want the time to talk through treatment options, to talk through their symptoms, to explain if they're looking at HRT, well, which HRT and how does that work? And how would I use that? And how would that fit in with my life? And what's available? So they want the time to go through these things. And I think that's completely understandable.
Thank you. Now let's think about the future, a future care model which is continuous, personalized, and scalable. One question: how do we achieve that? And probably the second question is from Kate, from clinician patient perspective, paint a practical picture of the ideal future care model for perimenopause.
Wraparound care, I would say. And I'm particularly thinking about patients who go through menopause at different age groups. So you could have younger patients, as we've said, in their teens, 20s, 30s, surgical menopause, medical menopause. It isn't just, as we've said, the patient coming and having, a discussion, well, we think it's menopause, we're offering HRT. It's actually that wraparound care. So what does that mean? Does that mean that we need to think about the long term, as we said, implications for bone health, cardiovascular health? Do we need to think about symptoms right now? Do we need to think about other supports? So I think for me, having that whole wraparound care rather than just possibly fragmented single visits, I think would benefit the patient hugely. They want continuity. If you ask patients that I see, what is it that you want? They want continuity. They don't want to feel like a number. They want to know that they've got continuity. They've got a safe, experienced practitioner who's supporting them and advising them. But on the other side, they also understandably want to have evidence-based information and data. Women want to know more about their health. They're now curious. They're not afraid to ask questions. And we should be able to support them to do that and be able to feel trained and experienced to answer those questions.
And if you had a, let's say, magic wand, what kind of changes would you desire to make with that magic wand?
Training for all healthcare professionals, so not just doctors, but all healthcare professionals, because as I once said to a nursing student who said, I don't want to work in women's health, so it's not relevant. So I'll say, so you're never going to treat a woman ever in your nursing career? Because you might meet that woman in a completely different place. We can all relate if we've seen patients and they'll come in for one thing, yet something else will be actually what they want to talk to you about. So even if you've just got a bit of basic knowledge, you can make a huge difference. I had a wonderful student who did some research about nurses' knowledge of menopause, student nurses, and it was very, very low because, again, the assumption was, you must learn about this in your training. But if someone asked me or many other nurses, no, most of our training is post-qualification, either training we've chosen to do or we've accessed, and that's very much the same for other healthcare professionals. So if we could offer mandatory education to all healthcare professionals and continuing professional development so that they can continue to update their skills, that would be my magic wand. I know some of the other panel members will have different magic wands, but that would totally be my magic wand, because training is becoming more and more of a challenge with funding for us as healthcare professionals in time.
Yes. Funding and training. Nivedita, think about the overall ecosystem, the public, private partnerships. Think about innovations, government support. What is your magic wand and what that magic wand is going to enable for the future care model?
I think the future care model, like all the others are also talking about, it needs personalized medicine or personalized healthcare, right? So if I'm going to the doctor, I want the doctor to know all my history, to know all my data, and then do the correct diagnosis. And for that, I think data plays a big role. And my magic wand would be really if all the data coming from all different sources could be somehow connected, which helps the doctor to make the right decision, and it has a longitudinal data. I think that will solve a lot of challenges that we have. I mean, of course, there needs to be training and awareness and all that, but that would be something that I bet on can help a lot.
And how efficiently we could, collect that data, make sense out of it? Is it what kind of partnerships, what kind of innovations or funding need to be enabled to make that happen?
I mean, now we have these wearables. I think that's is like, collecting data every second. And then you have the apps, digital apps that collects the data. So I think there are innovations already happening in different parts of the world, and also in the ecosystem or the system of the healthcare. So it's now, if we have like a standard framework, because each data has to have like a separate data type, and are they talking to each other? So I think that kind of standardization on a higher level that needs. So whether I'm based in Germany and the other person is based in US, but if I'm traveling to US, so my data should travel with me. So there needs to be a standardization of, okay, these are the frameworks that we use, and this is how the data should travel.
Makes sense. Interesting. Revital, from your perspective, what your magic wand you would want it to do?
Well, we're building it. That's what actually. I mean, we are working very hard for the fact that to actually bring into real life the fact that in a few years' time, women will start getting a baseline then for their multimodal tracking. So if you start in the 30s and you get it once a year, it becomes a screening test for when a woman actually enters perimenopause. Then you can say if she entered it at 35 or 37, and you can prevent all that spiral, all that downward spiral that happens later on. I mean, our dream is to not. I mean, currently we're already helping women feel better faster. That's our current focus, but where we want to be in a few years' time is to actually prevent all that. We want to be there in advance and help doctors balance, help them keep the balance from the beginning and not lose it and then try to regain it. There are so many things that we know actually start deteriorating or already in the 30s. If you're talking about bone loss, it starts so much earlier. I mean, today, usually they check it at around 60 and it starts even before 40. So we have to have that continuous tracking done in advance to help women understand where they are before they start deteriorating.
Interesting. And Nivedita talked about data collection through wearables. Do you think wearables are enough for collecting all kind of data, or that requires more help? What do you think?
Well, we actually think that the real wearable is a smartphone. If you look at the population wise, the one thing that everybody wears on is their smartphone all the time, every day, and that's why we used it. Because I come from a background in consumer goods, and I know how slowly penetration walks in through wearables. You have exactly so many different kinds of wearables, different protocols, different companies. It's very difficult to integrate. And we came from actually that view, and we said, how can we have something which is really, as open as possible, open to everybody, accessible to everybody. If it's talking about cost and devices that have different constraints. So that is actually why we went on the virtual route, and it's incredible what can be done. I mean, even without a baseline, we can determine if a woman is perimenopausal or not through a smartphone photo, so selfie photo. So it's incredible, and that's with today's technology. It keeps on improving, but again, we think that's the most common actually device that everybody has that allows for this virtual data collection and
Yep,
yeah,
makes sense. Dana, you have been listening very patiently. Any thoughts from your side on the diagnosis or the care model or on the future?
Yeah, you talked about magic wands, so it's exactly the combination of doctors that knows what they're talking about and well educated, and the data that is so missing today, and that's our dream, to combine these two aspects and give women the treatment they deserve.
Fantastic. Thanks a lot, all the panelists. I think it has been a fantastic, very insightful conversation. Obviously, if we are able to achieve all the right kind of innovations with the right kind of funding and training for the doctors, then that will definitely create the ideal world for women. This has been a fantastic, panel with the right kind of panelists, and probably I was the misfit moderator, but I tried to do my job. So again, really appreciate it. I think we have heard a clear consensus. The current diagnostic model, while well-intentioned, too often leaves women waiting for the label instead of receiving the continuous data-informed support that they need. Delayed diagnostics, episodic care, and symptom-only approaches are not serving the complexity of perimenopause. I think we need to do a lot in this space, and Nivedita is working on it, Revital is working on it, Dana, Kate are working on it. And if we are able to bring all the right partnerships between the insurance companies, healthcare professionals, innovators, investors, then we can make it happen. Thanks a lot for joining us today. And I'm sure that we will have more similar conversations to talk about how the future should look like, what challenges we need to solve today. And I hope that we can explore synergies, explore partnership opportunities to see how we can collaborate and make this ecosystem even more efficient for women. So thank you. Thanks a lot for joining, and we'll talk soon. Thank you. Bye. Take care.
Okay.